Okay, well, as I said, welcome to everyone to Pediatric Teaching today. This is the fourth session we've had about pediatric cardiology, about heart disease in children. And the first session was regarding how to read a pediatric ECG. And then in the second session, we talked mostly about left to right shunts. And in the third session, we talked about left to right shunts like ventricular septal defects and atrial septal defects and AVSDs and PDAs, etc. And then in the third session, we talked about the other causes of heart failure in children of different ages. And if you remember, we talked about the heart failure that occurs in newborn babies, often a baby born well, but then goes into heart failure or in shock. And we talked about heart failure that occurs in infants, often being left to right shunts. And then we talked about heart failure that occurs in older children and how that's different, how that's more often acquired cardiac disease like rheumatic heart disease or myocarditis or other systemic illnesses causing heart failure. So we mostly talked about acyanotic heart disease, and today I wanted to talk a bit about cyanotic congenital heart disease and another form of heart disease that causes cyanosis, which is pulmonary hypertension. So I'm going to separate the two, but firstly, we'll largely talk about cyanotic congenital heart disease. So as I said, in week one, we talked about left to right shunts, and week two, we covered the newborn baby who had shock. So if you remember, an infant or a child who's got left ventricular outflow tract obstruction, either from aortic stenosis or coarctation of the aorta or an interrupted aortic arch or something like that, a hypoplastic left side of the heart. And we did talk about older children with heart failure, for example, those with rheumatic heart disease or cardiomyopathies or myocarditis, etc. This week, as I said, we want to talk about cyanotic congenital heart disease. So particularly obstructed right ventricular outflow tract. It's analogous to the obstructed left ventricular outflow tract, but it's affecting the right side of the heart. And we'll talk about mixing lesions as well, and we'll talk about pulmonary hypertension. So these things we'll talk about today. So I wanted to remember last couple of weeks, the entry point to the discussion about different sorts of heart disease has been to try to find a typical presentation of these cases so that we know when we see certain clinical features in a child at a certain age, then you can recognize the pattern. So the first one is the infant or the child who has cyanotic episodes. And just like we discussed in the last 2 weeks, it's important not to just focus on this is cardiac disease or this is a tetralogy of Fallot, but also think about the non-cardiac differential diagnosis of the infant or the child who has cyanotic episodes, because they're not all cardiac disease. It's not all tetralogy of Fallot. There are other causes of cyanotic episodes in infants and children, and we have to start broad and then narrow down if we can exclude other causes beyond cyanotic congenital heart disease. And then the second scenario, the second sort of clinical scenario, is the newborn who's cyanosed at or soon after birth. And again, that has a broad differential diagnosis, and we'll go through those. But these are the two typical clinical presentations of infants and children who have cyanotic congenital heart disease. But again, remember, it's when we see a child, we don't know that they've got tetralogy of Fallot or that they've got a transposition of the great arteries. They've just got cyanotic episodes, or they're born with cyanosis. And we have to work through the cardiac and the non-cardiac causes to actually reach a diagnosis. So this is the brief case summary of an infant I saw some years ago in Kundiawa, actually, a 4-month-old boy who presented with seizures and collapse whenever he was upset or crying. In fact, whenever he passed a bowel motion, he would get cyanosed and he would have a seizure. And it seemed to be a very unusual story for this infant. But in fact, when you think it through, it's actually quite understandable by the pathophysiology. He was a normal-looking baby. He had normal pulses, and he was not cyanosed centrally or peripherally to look at. His chest auscultation was quite clear. He had no hepatomegaly, so there was no signs of heart failure as such, no signs of heart failure. In a good light, he had mild cyanosis and saturations of 88, especially when he was upset, but other times he wasn't. And so clearly there's a broad differential diagnosis of an infant who has seizures and collapse and some episodes of cyanosis when upset and crying. And you could think about it in broad terms. So the child could have a respiratory disease causing episodes of cyanosis, like breath holding spells, or even aspiration of milk or aspiration of food could lead to episodes of cyanosis, and what could follow would be seizures. It could be a neurological event, so some seizure disorders like infantile spasms or some other forms of epilepsy can lead to episodes of seizures with cyanosis because it'll affect the breathing. And of course, it could be tetralogy of Fallot, that clinical presentation of cyanosis and desaturation, especially when upset, is classic for tetralogy of Fallot. But again, I just think it's good to think broadly about, could it be a respiratory event? Could it be a neurological event? Could it be a cardiac event? Could it be an arrhythmia? Maybe the infant's going into episodic arrhythmias and then having low cardiac output, getting hypoxic and having seizures. So just again, think broadly about these things before you hone in on the exact diagnosis. This was the child's chest X-ray, and I think you'll all be able to recognise that there's an abnormal shape to the heart. You all know the classic boot-shaped heart. This child is not. The shape of the heart is classic, but there does seem to be some pulmonary vascular markings in the lungs, and sometimes you see the lung fields to be more translucent than this, more black, if you like, a lack of pulmonary vascular markings completely. But in this child, there's still some pulmonary vascular markings, and that just tells you. It tells you something. It tells you that there's still some pulmonary blood flow. It's not, and the infant saturations are being not very low. Not sometimes you see babies who've got tetralogy of Fallot and their saturations are 60 or 70, and there's very little pulmonary blood flow, so they have very oligemic or black lung fields. This infant had still a amount of pulmonary blood flow, except when he was upset or crying or passing stool, and he had increased intrathoracic pressure, which would reduce his pulmonary blood flow and therefore lead to hypoxaemia and a seizure. So try to recognise the infant sense like this, and but also think broadly about the other possibilities, like a neurological event or like a respiratory event, and exclude those things on history and clinical examination and X-ray changes. Almost always we can come to a diagnosis based on that history, examination, X-rays and an ECG. This is a tetralogy flow. So we're talking about cyanotic congenital heart disease. I think you probably know the aspects of a tetralogy of Fallot. There's four parts, isn't there? There's a very large VSD usually, which permits free flow of blood between the left and the right ventricle. And of course, normally, if there was a large VSD, then blood would flow from the left to the right and flow out the pulmonary artery, just like we talked about last week when you've got a large left to right shunt. What obstructs that is the hypertrophy of the pulmonary infundibulum, which is the muscle just below the pulmonary valve, and sometimes a narrowing of the pulmonary valve. So there's marked hypertrophy of the muscle of the pulmonary infundibulum, which means that as blood would like to flow from the left ventricle to the right ventricle and out the pulmonary artery, like with a big VSD, it's obstructed in its flow because of the hypertrophied muscle. And then, as you know, the third part is that what's called the overriding aorta, which just means when blood flows left to right, it can't go up the pulmonary artery, it goes back into the left ventricle and then preferentially out the aorta. So basically blood flows into the right ventricle and then instead of going through the pulmonary artery, preferentially goes out the aorta, because that's overriding means the aorta is just very close to the opening of the ventricular septal defect. So the path of least resistance is to go up the aorta. And what that does is just lead to reduced pulmonary blood flow, so therefore severe cyanosis. And when a child increases their intrathoracic pressure for whatever reason, they're crying, they're upset, they're straining, then they will have even less pulmonary blood flow, and the deoxygenated blood that's coming back to the right side of the heart from the superior and inferior vena cava will just go out the aorta. So you've then got blue blood flowing out the aorta, and that's why the baby is severely cyanosed. The infant who's got a tetralogy of flow is not normally cyanosed at birth. And remember I said there was two scenarios. One, the newborn who's cyanosed at birth, and the other one is the infant who has episodes of cyanosis in infancy, sometimes at 1 month or 2 months or 3 months, but not normally at birth. It's uncommon to see a baby with tetralogy of flow who's cyanosed at birth. In the first few weeks, the saturation may be normal or a bit low in the first few weeks of life, and typically the cyanotic spells develop sometime in the first 6 months of life. It does depend on how severe the infundibular stenosis is, and it also depends how much, as well as having a mechanical obstruction with hypertrophy, the pulmonary infundibulum, this part of the heart, can go into spasm, and that's what we call spells. It can go into spasm and lead to reduced pulmonary blood flow at various times. These children usually have a murmur, and it's a pulmonary flow murmur. You don't usually hear blood flowing through the ventricular septal defect. You sometimes can, but usually it's a pulmonary flow murmur. So an ejection systolic murmur at the upper left sternal edge, and it usually radiates to the back. So the clinical features are an ejection systolic murmur, a baby who's got episodic cyanosis, a boot-shaped heart, typically, usually oligemic or translucent lung fields, and that's how you can make the diagnosis. The treatment of we all have managed, I'm sure, infants who've got tetralogy of Fallot and tried to treat their cyanotic episodes. Sometimes they're quite extreme. The baby will desaturate to below 50% oxygen saturation. Sometimes it's almost unrecordable, down to 20% or less, and you think that the baby's going to need some sort of resuscitation. But usually, if you can calm the baby, if they're distressed, then usually they will calm and their saturation will improve. They'll start breathing again. So always give them oxygen. I generally give them a dose of intramuscular morphine. You might think that might suppress their breathing even further, but a small dose of intramuscular morphine just calms them. It reduces their infundibular spasm, and usually then they start breathing. So oxygen, often an intravenous fluid bolus, if you've got a drip in, is helpful, because that increases the blood flow through the pulmonary valve, which is what you want to do. You want the blood to be flowing through the pulmonary valve so that there can be oxygenation of that the blood flowing through the lungs, and then giving some propranolol, which can reduce the spasms. That's certainly something that these babies should be on long term. And as you probably know, most of these children acquire a certain posture when they're having these spells. If they're old enough, if they're toddlers are older children, they'll go into a squatting position, a sort of knee-chest position. And what that does is it increases their systemic vascular resistance so that less blood flows through the aorta and more blood can flow through the lungs. So if you put a baby in that sort of squatting position, even if they're lying down, give them some morphine to settle them down, give them an IV fluid bolus and plenty of oxygen, then usually these episodes of cyanosis can resolve. I said that in the first week, we should try to integrate the history, the examination, the X-ray changes, and the ECG in making a diagnosis. And I hope it won't be a surprise to you now to think through what the ECG changes should be in an infant who's got severe tetralogy of Fallot. And if you think about the anatomy, they've got marked right ventricular hypertrophy. And so therefore you would expect that they'd have large evidence of right ventricular hypertrophy on their ECG, which, if you remember, they are likely to have tall R waves in V2 and deep S waves in V5. And indeed, this infant has in V2, 5, 10, 13, and deep S waves 5, 10, 15. So getting up there to 30 or 35. And this is an infant who had tetralogy of Fallot. You can also see a peaked P wave here, and the peaked P wave indicates that there's right atrial hypertrophy. And so infants with tetralogy of Fallot have high right atrial pressures and are likely to develop over time right atrial hypertrophy and plenty of evidence of right ventricular hypertrophy. So the ECG can help our diagnosis in confirming, I suppose, what we see we find on history and examination and X-ray changes. Sometimes infants with tetralogy of Fallot will also have a right bundle branch block. Again, not surprising, because they've got such a hypertrophied right ventricle that it takes a long time for the electrical impulse to go around the right ventricle. So they'll have a right bundle branch block, a delayed conduction through the right ventricle. This infant doesn't. This is an infant with a tetralogy of Fallot, just has evidence of right ventricular hypertrophy and right atrial hypertrophy. The infants who have tetralogy of Fallot also often have a right axis deviation. And if you remember, the way you assess the QRS axis is that you need to look at lead 1 and lead AVF. And if we go back, I think I can go back, yeah, look at the net deflection in lead 1 and in lead AVF. And the net deflection in lead 1 is very negative, so 5, 10, 15, 20 down and 5 or 6 up. So therefore it's a net deflection of -14. And there's a positive deflection in lead AVF. So where are we? 5, 10, 12, something like that. So when you're looking at your the quadrants, the -14 and +8 will lead to a large right axis deviation, which again, this is it's sort of, if you put it together, it's understandable, because the infants with tetralogy of Fallot have right ventricular hypertrophy. They have a more dominant right ventricle, so therefore relative to their left ventricle, they'll have a right axis deviation. The voltage axis of their heart is more towards the right. It's again just a clue that this is probably a right-sided hypertrophied heart lesion consistent with a tetralogy of Fallot. I won't go through this again. We talked about this before, but remember I said that infants are more likely to have a right-sided axis, and as they get towards about 2 or 3 years of age, the axis shifts towards what the normal adult axis is, which is between 0 and 90 degrees. The main thing to remember is that a right axis deviation can be normal, but it's not usually as extreme as this, where there's a marked right axis deviation, like with this ECG, especially if the child's in older infancy. So the main thing is to know how to assess the axis of a child, and to know when it should return to the 0, 90 degree axis that an adult has. We talked about this in a previous lecture. I wanted to we see a number of children who have tetralogy of Fallot either presenting with episodes of cyanosis in the first year of life, or they may present later. They will have a known tetralogy of Fallot, and they may present later with complications of tetralogy of Fallot. And usually if a tetralogy is repaired, then these complications are much, much less likely. But if a tetralogy is not repaired, then the complications they're highly likely to get at some time in their life, like this boy, who was a 10-year-old boy with tetralogy of Fallot. You can see his marked clubbing, and he has a cerebral abscess, And the reason why he got a cerebral abscess is, I hope it's understandable to you, but all the time we're getting tiny little clots that form in our veins, and normally those clots get filtered out as they're going through the lungs. If you've got a right to left shunt, then those clots, that minuscule microscopic clots that might form in your veins that go back through the veins to the right side of the heart, if you've got a tetralogy of flow, they can quickly go up the aorta and then to the through the carotid arteries to the brain, and they're much harder to filter out if they get to the brain. And so occasionally we will get clots that have some bacteria on it, and then they will lodge in the brain, and if you've got a tetralogy of flow, and lead to a cerebral abscess. That's usually the mechanism, because of the right to left shunt. And most of us who don't have a right to left shunt, we have a mechanism in our lungs that filters out those bacteria that are linked to tiny microscopic clots, and they don't cause a problem. But it's not uncommon to see children with tetralogy of Fallot develop cerebral abscesses or strokes from clots that go from the right side of the heart to the left and up the aorta and into the cerebral circulation, leading to a stroke. So it's common that these children will suffer this complication. The management of tetralogy of Fallot is first advise the parents on home care of cyanotic spells. I always teach the parents how to manage them, just like I showed you before with the knee chest position. Have the child on propranolol. Many of these children, as they get older, not in infancy, but as they get older, can, because of their chronic hypoxaemia, develop a hemoglobin that's very high. They have a adaptive response where they produce lots of erythropoietin, and their bone marrow produces lots of red cells, and their hemoglobin may be 20 or 25, very, very high, and that can lead to hyperviscosity, and that can increase their risk of stroke. So this child, for example, ended up with a hemoglobin that was over 20, so he would come in regularly for venesection to bring his hemoglobin down to about 15 to 17 to make sure that he wasn't too hyperviscous and to have a stroke. Of course, these patients ideally should have a complete repair sometime in infancy, or usually in infancy these days they're being repaired. And if they can't be repaired, then having a shunt is important. You all know about the Blalock-Taussig-Thomas shunt, probably, that can augment their pulmonary blood flow usually from the left subclavian to the pulmonary artery. That's a Blalock-Taussig-Thomas shunt. As I said, the long-term complications are progressive right ventricular outflow tract obstruction and other conditions such as cerebral abscess or stroke. And then even after repair, some children can have complications, but most children after a complete repair can lead normal lives and be free of those other risks. They need antibiotics when they're having a procedure to make sure they don't get endocarditis, but otherwise they can lead quite good lives. Okay, so that's I wanted to, the entry point was infants who have episodes of cyanosis, and the other common clinical presentation of cyanotic congenital heart disease, the different clinical presentation, is the newborn with cyanosis. And again, we sometimes see, last week I talked about the neonate who's well at birth and then collapses in the first week or the first couple of weeks with shock. That's different. Those children typically have obstructed left-sided heart disease like coarctation or aortic stenosis. But the newborn baby who's cyanosed from the first day of life, that's another presentation that they're different. The newborn baby who's cyanosed in the first day of life is much more likely to have some sort of obstructed right ventricular lesion or a large mixing lesion, like a transposition of the great arteries. It's really just understanding that there's a distinction between these two things: the baby who's well at birth and then collapses, compared with the newborn who's cyanosed at birth. And the newborn who's cyanosed at birth may well have other things. We often think of, more commonly, birth asphyxia or congenital pneumonia, maybe some other respiratory problem like an airway abnormality or diaphragmatic hernia or congenital heart disease. And the common, as I said, the common congenital heart disease where a newborn is cyanosed at the time of birth in the first hours of life is a transposition of the great arteries. And I think you know the anatomy of that, where the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. So there are parallel circulations. The circulations run in parallel, not in series. And of course, that's incompatible with life. A baby can't survive if there's not blood from the right side of the heart going to the left and then circulating around the systemic circulation after oxygen has been put into the blood. But most babies who have a TGA, a transposition of the great arteries, have a mixing lesion as well. And usually that's a patent foramen ovale or a patent ductus arteriosus, or quite commonly a large VSD. If they've got a large VSD, then they'll have what's called a complete mixing lesion, and they'll be deeply cyanosed, but they'll still have an not adequate, but they'll still have circulation of some oxygen going to the systemic circulation. If they've got just a patent foramen ovale or a patent ductus arteriosus as their only source of mixing, then inevitably in the first few hours or day or so, the duct will close and they'll become deeply cyanosed, and they won't, that too is incompatible with life. So the ones who survive have a large ASD or a VSD that provides that mixing between the left and the right circulation, and then there can be oxygenated blood going systemically. So the presentation of these babies is that they have cyanosis in the early hours of life, and that progresses over the first few days. They usually have a metabolic acidosis because they've got reduced oxygen delivery to tissues. The baby's blue and tachycardic, and they have a strong right ventricular impulse because they've got a hyperdynamic circulation trying to pump blood around the body. They often have no murmur. Again, surprisingly, just because they don't have a murmur doesn't mean they don't have congenital heart disease. And they have an X-ray that shows a heart shape that you might say, well, is not too abnormal. But if you think about what an egg on the side looks like, I know you know that this characteristic, but if you turn an egg on the side, this is what the heart looks like. And this is typical for a transposition of the great arteries. It doesn't look like a boot-shaped heart. Remember, it's different to a boot-shaped heart, and it's partly different because there's not oligemic lung fields. There is enough pulmonary vascular markings. In fact, sometimes the lung fields can be a bit congested, but the heart looks like it's turned on, an egg turned on the side. And again, remember I said most of pediatrics is about pattern recognition. And so if you can recognize that pattern of the newborn baby who's cyanosed at birth, who has these features and has a chest X-ray that looks like this, an egg on the side, and there's no other features of some other non-cardiac illness, then you can probably diagnose a tetralogy of transposition of the great arteries. There are some other cyanotic congenital heart disease that can lead to cyanosis at the time of birth, and these are a bit like a very severe tetralogy of Fallot, which is pulmonary atresia, which is just a more extreme form of right ventricular outflow tract obstruction, pulmonary atresia, or tricuspid atresia, where there's no blood going from the right atrium to the right ventricle, or no blood going out the pulmonary artery. And then sometimes a truncus arteriosus, where which is actually more common in PNG, where there's a single outflow tract, a large VSD, a single outflow tract from both the left and the right ventricle, and large VSD, and there has to be a balanced circulation between the left and right circulations. I won't talk too much about truncus arteriosus, but I think it's just important to be able to recognize the that clinical scenario of the newborn baby who's cyanosed at the time of birth and recognize what type of congenital heart disease they may have, compared with the infant who has episodes of cyanosis at 2 months or later, and recognize what type of cyanotic congenital heart disease they may have. Okay. It's worth thinking about, through the last few weeks, I've talked about different murmurs that children may have, and it's worth thinking through where the murmurs are for different cardiac illnesses. And I think I think if we practice listening to murmurs, we can all get good at it. It seems very complex at the start, but if you can, when you listen to a murmur, think to yourself, where is the murmur heard loudest? What type of murmur is it? Is it a murmur that's systolic or diastolic? And if it's systolic, is it pansystolic, going all the way through from the first to the second heart sound in an equal sort of sound, an equal sound going all the way through? Or is it a murmur that gets louder and then softer, but you can clearly hear the first and second heart sound? Is it an ejection murmur or a pansystolic murmur? And then ask yourself, where does the murmur radiate to? So where is it? What type of murmur is it? Is it systolic or diastolic? If it's systolic, is it pansystolic or ejection systolic? Where is it loudest? And where does it radiate to? And if you can ask yourself those 3 or 4 questions when you're listening to the heart, then you can diagnose. You can not confirm the diagnosis, but you can get much, much closer to a diagnosis, a clinical diagnosis of the type of cardiac disease a child might have. Remember, for example, if you hear a loud pansystolic murmur at the lower left sternal edge, so a pansystolic murmur going, a very loud whooshing murmur that goes from the first to the second heart sound. If you hear it in the lower left sternal edge, then you should ask yourself the question, where does it radiate to? And if it radiates under the xiphoid process, then almost certainly it's a ventricular septal defect. If you hear it louder at the apex and it radiates into the axilla, then it's probably mitral valve regurgitation. And again, putting together the clinical picture, if you've got a 5 or 8-year-old child who's got a pansystolic murmur that's at the apex, radiates into the axilla, into the left axilla, then probably they've got mitral regurgitation, and possibly they've got rheumatic heart disease. If you've got an infant or a young child who's got a murmur at the lower left sternal edge and it radiates down below the xiphoid process, then likely they've got a septal defect. And again, it's just putting together this pattern of the age of the child, the history, the examination, the cardiac auscultation, the chest x-ray and the ECG. If you put it all together, then you'll make the diagnosis. I won't go through all of these, but you need to just think about what type of murmur it is. Is it systolic or diastolic? If it's systolic, is it pansystolic or ejection systolic? Where is it best heard and where does it radiate to? And if you do that, you'll be able to make the diagnosis of most of these types of congenital heart disease. The aortic area is the upper right sternal edge. The pulmonary area is the upper left sternal edge. Remember we said an ejection systolic murmur in the upper left sternal edge is likely to be an atrial septal defect, or it could be a pulmonary flow murmur, such as occurs with the Tetralogy of Fallot. If you heard a continuous murmur there going through systole into diastole, then it's sometimes called a continuous or hollow systolic murmur, and that's likely to be a patent ductus arteriosus. And in that case, with a PDA, you should feel wide and bounding pulses, shouldn't you? Or wide pulse pressure and bounding pulses. We talked about that in the first week. And again, putting that pattern together, you can diagnose then a patent ductus arteriosus. I won't go through all of this, but I'll send this around so you can just study it perhaps and be clear about where murmurs are best heard and what they mean. And then practice it. Listen to lots of murmurs and try to think through this process of what type of congenital heart disease they may have. I wanted to lastly talk about pulmonary hypertension, and that's partly because pulmonary hypertension is quite common in PNG, and it's common for several reasons. One is that in some settings, like in the highlands, pulmonary hypertension is common because of altitude and the frequency of.
Bapak belum pulang loh. Walah, ya mau pulang.
I think someone's got there.
Oh, okay, yeah.
If someone's got their device on, can you just mute your device, please, if you can? Thanks. Thank you. Right. Yeah, pulmonary hypertension is more common in some settings. Again, in the highlands, it's more common because of the frequency of pneumonia and altitude, and the frequency of hypoxaemia. All predisposes to pulmonary hypertension in children who have severe pneumonia. But it's also quite a common clinical problem, pulmonary hypertension, because of the frequency of chronic lung disease. And for children who have bronchiectasis or TB-related bronchiectasis or HIV-related lung disease, those children, it's not uncommon for those children to also have an element of pulmonary hypertension. And so I think we need to be good at recognition and management of pulmonary hypertension. I just wanted to go through a few features of pulmonary hypertension, and maybe we can discuss it or answer any questions. But most of these children present with recurrent or persistent respiratory distress. They may present with frequent episodes of what is thought to be pneumonia, what may be episodes of lower respiratory tract infections. They will have episodes of oxygen desaturation, a little bit like the child who's got tetralogy of Fallot. They may have episodes of severe cyanosis, often when they get upset too. So the child who has part of the differential diagnosis of tetralogy of Fallot in infants and older children is pulmonary hypertension, and but you can usually work it out based on the clinical features and the X-ray changes. They often, they often have hepatomegaly because if a child's got severe pulmonary hypertension, they've usually got right heart failure, and they have a congested liver from their high right-sided pressures. So they'll often have hepatomegaly. They'll almost always have tachycardia. They'll have a right ventricular heave, and they may have a loud pulmonary second sound. Now, it takes a bit of practice to recognize all of those. It takes practice to recognize all of those clinical signs in children. But again, if you, like I said, paediatric cardiology is about pattern recognition. And so you need to know what the clinical features are of pulmonary hypertension and practice recognizing those. As I said, the reason why pulmonary hypertension is more common in PNG than it is in other countries, in other settings, is that there's a lot of children who have unrepaired congenital heart disease that gives a high left to right shunt. So those children will have some pulmonary hypertension. There is some children who have pulmonary venous hypertension, that is, they've got mitral valve stenosis. So therefore the blood pressure in their lungs will be higher. And then there's children in the highlands and maybe elsewhere that have altitude associated hypoxic pulmonary hypertension. So they get pneumonia, they get hypoxic, they have pulmonary vasoconstriction, they get high right-sided pressures. Usually they don't go into very severe right heart failure, not like in children with idiopathic severe pulmonary hypertension or severe chronic lung disease, but they may have an element of right heart failure at the time they have their pneumonia, and that needs to be managed as well. And then there's the children who've got chronic lung disease with bronchopulmonary dysplasia or pulmonary fibrosis or some other form of pulmonary disease that leads to right heart failure with pulmonary hypertension. And then occasionally children who've got pulmonary vascular problems like pulmonary emboli, or certainly during COVID, we're seeing a lot of older children who had lung pulmonary emboli with pulmonary hypertension. And then there's some nutritional risk factors too. If you've got vitamin C deficiency or thiamine deficiency, then those children are more at risk of pulmonary hypertension. So there's a number of different risk factors for pulmonary hypertension, and usually it's one or more of these that can be identified as a cause of a child's pulmonary hypertension. The definition is important, and by normally the pulmonary artery pressure is much lower than the systemic artery pressure, and the definition based on the International Cardiology Society is a pulmonary artery pressure more than 20 millimeters of mercury. Usually we don't get too worried until the pulmonary artery pressure is more than half the systemic pressure, and often more than 2/3. And sometimes children with pulmonary hypertension, when they've got a pneumonia, their PA pressure rises a bit. It's when it gets to 2/3 or more than a half of their systemic pressure, then you start to worry that it's going to have an effect on their right heart. Now, the reason why the high pressure in the lungs affects their right heart is that mostly the right ventricle is not a very strong ventricle. It's not made for pushing against a high pulmonary vascular resistance. It's the weaker of the ventricles. And so when the pulmonary artery pressure is high and the ventricle has to press contract against a high pressure, then sometimes the ventricle adapts and becomes stronger and more hypertrophied. And sometimes if the pressure is very high, then the ventricle fails. I'll explain what happens when the ventricle fails, but you need to know what the definition is. So a mean pulmonary artery pressure more than 20 millimeters of mercury. Usually the pulmonary vascular resistance falls very much at birth, doesn't it? It's equal at birth between the systemic and the pulmonary vascular resistance, but the pulmonary vascular resistance falls a lot at the time of birth when the baby takes their first breath. But some babies have persistent pulmonary hypertension because their pulmonary vascular resistance remains high, maybe because they've had some birth asphyxia or hypoxaemia. So that's PPHN, that's persistent pulmonary hypertension of the newborn, which is different to the pulmonary hypertension we were talking about among children in the highlands at high altitude, or children who've got chronic lung disease, or children who've got large left to right shunts. I won't go through the rest of it, but I think most of this I've explained. Often the typical X-ray features of pulmonary hypertension is that the pulmonary arteries look very large. And you might look at this X-ray and say, well, it looks like there's some pneumonia or big lymph nodes in the perihilar region, but actually this is the left and the right pulmonary artery being very large. They're usually in severe pulmonary hypertension, the pulmonary arteries are larger, often larger than the aorta. And of course, usually the aorta is the largest vessel in the body, but if a child's got severe pulmonary hypertension, often their pulmonary arteries are even larger. So if you see an X-ray like this, of course, think about the possibility they've got big lymph nodes, perihilar lymph nodes, but it may be that they've got large pulmonary arteries. That's what this is, very large pulmonary arteries. Again, this is another different child who's got severe pulmonary hypertension. You can see the large left and right pulmonary arteries and extensive pulmonary congestion around the perihilar region. And you might look at this and say, well, they might have pneumocystis or they might have TB, but they could also have pulmonary hypertension with very high pulmonary artery pressures and large pulmonary arteries. And you can see this, I mean, you can often see this on echo. I'll talk about echocardiography maybe at a later time, but there's different windows you can look at to see different aspects of congenital and acquired heart disease. But there's particularly two echo windows that you can look at to diagnose pulmonary hypertension. And I won't go through all these different windows today. Perhaps we'll just talk about the ones for pulmonary hypertension. For pulmonary hypertension, the best window is the parasternal short axis view, which is up in the second left intercostal space. And what you usually see this is the normal, where you've got the large left ventricle, which is thicker, the large left ventricle, which is thicker, and then the smaller right ventricle, which is off to the side. If a child's got severe pulmonary hypertension, then their right ventricle will often be very dilated. This is the interventricular septum, and you'll see how squashed the left ventricle is. And this illustrates what actually happens in a child who's got severe pulmonary hypertension, who has, because of that, has gone into right ventricular failure. The reason why they get so unwell is that their right ventricle dilates, that puts pressure on the interventricular septum, and therefore their left ventricle can't do the work. That means blood can't fill the left ventricle, and there's not enough blood can flow out of the left ventricle because the stroke volume of the left ventricle is much lower. So this is what pulmonary hypertension can look like on the parasternal short axis view of an echo of a child. This is a child with pulmonary hypertension. And similarly, in the other view for diagnosing pulmonary hypertension, it's the apical 4-chamber view, which where you put the probe at the apex and look for the 4 chambers. Sometimes the atrium are at the top and sometimes at the bottom. You need to adjust accordingly. But in this circumstance, you can see that the right ventricle is very large compared with the left ventricle. And the intraatrial septum, which is, I'll just mute this person, I think. The intraatrial septum, which is normally bowed to the right side, is straight. And so you've got a very large right ventricle that is filling with blood, that is pressing against a high pressure and leads to reduced blood flow into the left ventricle. It's more complex, but I just want you to recognize the clinical features of pulmonary hypertension largely, and sort of know what it looks like on echo when you look at those 2 views, the parasternal short axis view, where you see the ventricles in cross section, and the long axis view, where you see the length of the ventricle and the intraventricular septum and the atrium. This is a CT scan, and I won't go through this too much, but I showed you before the plain X-ray. And remember I said that sometimes the pulmonary arteries are much larger than the aorta, and this is the aorta and this is the pulmonary artery. So you can see how dilated. This is a child who's got severe pulmonary hypertension related to pulmonary vascular disease and chronic lung disease, and you can see how large this is a CT angiogram where contrast has been injected, and you can see this is the left pulmonary artery being extremely large relative to the aorta. This is the aorta here, so the diameter is almost twice as much, or 1.5 times as much. So I won't talk too much longer, but I think we need an approach to pulmonary hypertension, and the first thing is to make the diagnosis. And I've talked about the clinical features that you can see and the radiographic features sometimes, but we need to find the cause, and there's all the different causes that you can get an idea about based on the history and the clinical examination, the context of the child's presentations. You need to decide, is it primary cardiac or respiratory? In a child who's got pulmonary hypertension, they might have a large left to right shunt, like a big VSD that's unrepaired, or they might have chronic or acute respiratory disease, or they might have pulmonary vascular disease. Then we need to ask what part of it is reversible. And usually there's a part of the pulmonary hypertension that's reversible. If the child's got pneumonia, you can treat, or the child's got hypoxaemia, you can give oxygen for. Or what part of it is not reversible? Is some of it chronic, or is it acute? And then sometimes there are other reversible components, like some children, I've seen children who've got severe nutritional depletion with malnutrition or micronutrient depletion, and their pulmonary hypertension is just due to vitamin C deficiency or just due to thiamine deficiency. But think to yourself, if you see a child with pulmonary hypertension, could their pulmonary hypertension be contributed to, not caused by, but contributed to by vitamin C deficiency or thiamine deficiency. There's a biological reason for that, in that both thiamine and vitamin C are related to nitric oxide production. And when you've got an absence of nitric oxide production, nitric oxide is a potent pulmonary vasodilator. And if you don't have it, then children can have high pulmonary vascular resistance and pulmonary hypertension. It's actually a part of severe scurvy. If you in a child who's got severe vitamin C deficiency, I've seen children who've had such severe pulmonary hypertension they've needed extreme resuscitation from that. You should supplement their vitamins, treat their heart failure, and with diuretics, and typically with diuretics, and then consider the role of sildenafil. Sildenafil, as you know, is a nitric oxide donor, what's called a phosphodiesterase inhibitor, a little bit like aminophylline, but different. We use sildenafil for lots of children with pulmonary hypertension, but you should think about whether or not it's useful or maybe not useful. And for most children who've got idiopathic or lung-related pulmonary hypertension, it will be useful. For children who've got large left to right shunts, like ventricular septal defects or ASDs, it won't be useful, because all it'll do is increase the shunt, reduce their pulmonary vascular resistance, and increase their shunt from the left to the right ventricle. So it can actually make their pulmonary hypertension worse. But for many children who've got chronic lung disease, for some children it can make it useful, make it better. For children who've got fixed pulmonary vascular resistance because they've got severe cystic fibrosing lung disease, it's often not useful, because it doesn't cause vasodilatation. It won't hurt, but it just won't help either. So sildenafil is not magical for pulmonary hypertension, but it can be of use for some children. I think this is getting into very personalized and individualized medicine for the management of children with pulmonary hypertension, and it's worth, I guess, thinking through for this particular child what would benefit them if you see a child who's got pulmonary hypertension, and going through the process of working that out. There are some general things you can do, and then there's some specific things for that individual child. All right, well, that's about all I wanted to discuss today. I think at some other time we'll go through echocardiography in a bit more detail, but I think these last 4 weeks we've tried to cover the range of children who've got common forms of cardiac disease, and so hopefully that's been useful to you in your study and learning about cardiac disease. I'm going to stop the recording now and